All right, everybody. Welcome to a new round of TMAR. We got Mario, who's taking Navi's position today, and he's going to present a case to us. So, Mario, can you read the case to us?
Yeah. So this was a case that we got 2 nights ago. The patient's a 59-year-old man, not a significant medical history, hypertension, AFib, both are well controlled, right? Who's coming in with his wife, right? And the complaint really more from the wife is that he seems a little bit more confused and just seems off, right? He follows with one of the primary care clinics here. You go through his meds, you see that he's on aspirin, metoprolol, and Crestor. He's had an ablation for AFib back in 2017. He lives with his wife and 2 children. He's a bar and restaurant owner and has a remote smoking history of 15 pack years.
All right.
What do you want to know?
Any alcohol?
Social alcohol use, maybe he says about 3 to 4 drinks, maybe 2 nights a week.
Any changes in
parlor.
his stool?
So what was that?
Any changes in his stool in like quality or quantity?
No change in neither the quality or the quantity of his stool.
Mario, can you clarify about his confusion? What exactly is going on? Is he forgetting things? Is he not making sense?
It's been going on for 2 weeks, right? Before this, he was in his usual state of health. He and really mainly again his wife describes that while they can have a conversation, the conversations aren't as engaging. He's not doing as many tasks around the home. Seems a bit more withdrawn overall, right? And sometimes when they agree to do something in the house, he just kind of like forgets what he's doing or forgot to do something that seems out of the usual for him. Any inciting event over the last 2 weeks? None that either he nor his wife can pinpoint.
Any weight changes?
In review systems, you do find a bit of weight changes. In the past 2 months, he's had about a 10-pound weight loss. Location description of the pain. His pain is throughout the abdomen, right? Doesn't change really with food. Doesn't get any better or any worse. He feels like it's about to get better when he goes to the bathroom. When he goes to the bathroom, the pain just kind of comes back. So maybe it gets a bit relieved when he goes to the bathroom. And it's really, he also feels it kind of like deep in his lower abdomen and in his pelvis and towards his back.
Anything else?
Any other associated symptoms like peripheral neuropathy? No, not peripheral neuropathy, but he does actually describe significant lumbar spinal pain. Actually, and that's been going on for 2 weeks as well. He says that it's separate and different than his abdominal pain.
And all of this is 2 weeks ago? The pain, lumbar?
Yes, the only thing that is not 2 weeks ago is on Revere Systems is his about 15-pound weight loss over the last 2 months. Everything else is within the last 2 weeks.
Any difficulty with urination, like not being able to urinate or incontinence?
No, actually no difficulty with urination, no increased urinary frequency. What were you thinking of with that question?
Well, in someone with weight loss, I want to do a review of systems for any spinal masses that's like a compressing spinal mass.
Okay.
All right.
I had a patient with a spinal mass with like referred pain to the abdomen, so I always think of that now.
Very good thought. Very good thought. All right, so I think we're going to do this maybe a little bit different. Any more questions? Any more questions till we move on a bit?
Sorry, I think I missed it. You said no change in stool. But I'm assuming that means like no blood.
Correct. Yeah, no blood, no change in consistency. It's not no change in color. It's not floating. It's not more greasy.
Frequency?
Not so he feels like he has to go more often, but he's actually not going more frequently.
Okay.
And he associates that more with his abdominal pain.
Any family history of autoimmune disease or IBD?
No, I mean he had a pretty unremarkable family history. Actually, hypertension, diabetes in the family.
What kind of fib does he have?
Sorry, what kind of what?
AFib permanent, or like is he in fib now?
Paroxysmal atrial fibrillation.
Was he ever on anticoagulation for AFib? Or he's always just been on aspirin?
Aspirin.
Why?
Good question, yeah. Chad Basketball 1.
That's one.
Yeah. Chad Basketball 1.
All right.
Yeah.
Maybe,
Go exam first.
yeah, let's do vitals and exam, I guess, real quick.
So for vitals, he was afebrile.
Were they all normal?
Yes, yeah, and vital signs were stable.
All right. Anything on physical?
So on physical exam, well appearing, no acute distress. Neuro-wise, he tracks you. Normal strength, no paresthesias. He's 8 times 3. However, struggles with certain commands and has some kind of word finding difficulty and trouble describing certain events. Hence why he tends to rely on his wife for this. And while he can give you follow simple commands like give you a thumbs up, he can't cooperate with finger to nose, for example. He struggles with, he does something else completely different when you ask him to do finger to nose.
So more that he was just more
Like he just can't follow that direction.
Okay. Right. So when I usually kind of think of altered mental status, I kind of put it into 2 buckets, one being primary, which is usually going to be more of a structural disorder, a vascular phenomenon, like a mass in the brain that could be cancerous, infectious, but, all of this makes it a lot less likely. Were there anything else on neuro? Anything else in the abdomen?
Normal gait.
Normal gait.
Cardiac-wise, he was in sinus rhythm at the moment. He had clear lungs to auscultation. With regards to abdominal exam, it was diffusely but mildly tender, right? No focality to his exams, to his abdominal exam. Otherwise, 2 other things, he had no scleral icterus. And lastly, he did have reproducible pain when you palpated through his spine over the lumbar spine. No costovertebral angle tenderness.
He did have pain at the lumbar spine?
Yes.
Okay. All right, I wasn't planning to go into this, but, I think there's, 2 types of reason that we always think about. There's kind of intuitive reasoning, and then there's more deliberative reasoning. So intuitive reasoning is like, okay, I see this patient, I put all the pattern together and I come up with a diagnosis quickly. But those diagnoses a lot of times are more susceptible to bias, things like anchoring bias, things like affective bias. Really, they're a little bit more able to be influenced by emotions, things that you've recently seen, things that you may have done past. So there's also deliberative reasoning, and deliberative reasoning is usually, okay, let's take a specific diagnosis, a specific presentation, or one aspect of his presentation, and create a differential diagnosis around that aspect. So I think one of the big one that has something that you can kind of remember pretty easily is altered mental status. So he's coming in and altered for 2 weeks. So what kind of things do you guys think of, that you really want to work up for really any patient with an unknown reason for altered mental status? And I kind of like the mnemonic MIST, or some people use moist. Okay. I just add an E and an R on it usually, and then an N. So Mr. N. And then you guys, shout them out. And I think as you shout them out, we'll start giving you these lab results back, or imaging, whatever you guys want.
Electrolyte disturbances and like hypothyroidism or hyper.
Perfect. Yeah. So that's kind of
Metabolic.
gets into metabolic. The biggest electrolytes that cause altered mental status, which ones do you usually think about?
Hypernatremia or calcium.
Perfect. Yeah. So sodium, calcium. Let's go through the rest before we give results. Second is, infectious. I mean, this patient, does not have any fevers, chills, and he's not really that old. I mean, in dementia patients, you really always have to do a UA, plus minus blood cultures. I think I got some stuff in the chat. S is structural, yeah. And like when I think of structural, that's kind of when I put that in that primary category. And I start thinking about like, do I need to get an MRI? Do I need a CT first, then an MRI? Am I worried about specifically primary brain lesions causing this altered mental status, which will more likely come with some focality of weakness, sensation loss, things like that. T is toxins. That's we're going to get from the history, physical, things like that. Anything with toxins that probably didn't get a urinary tox. So all patients should get a urinary tox. I don't think it was probably gotten in this case.
Neoplastic.
Oh, and I made N up. N is just nutritional. It just makes me remember, think about.
If he had a more significant alcohol use history, for example.
Yeah, think about B12, folate, thiamine.
He does not display honest confabulation of like a Korsakoff's, right? But that's something else to think about.
And what would you usually guys think with, see with Wernicke's? I've seen Wernicke's probably 2 or 3 times. What's a typical presentation of that?
Confabulation.
That's usually once it gets to the Korsakoff phase, but Korsakoff is when it's irreversible. Wernicke's is when it's reversible. Wernicke's usually going to have, you're not going to be able to walk very well, so you're going to have difficulty with ambulation. There we go. Ataxia, ophthalmoplegia. Yeah, exactly. So those are the big ones. And then as it progresses to Korsakoff, you can get those typical confabulation, things like that. I like R. A lot of people don't include this, but anytime, especially for hospitalized patients, start thinking about getting ABG because of hypercarbia. I just like to put this on here so I don't miss this, as patients, especially in the hospital, can absolutely get hypercarb, especially if it's a COPD patient or someone who has who's been on opioids, things like that. All right, so those are the ones that you should really always check. Does anyone know the indication to get a CT? I feel like this comes up all the time where someone's in the hospital and you're like, oh, they're altered. Like, do we get a CT? Does anyone know kind of when you do that? Because it always seems like, we'll just do it, whatever.
Commonly done in the ED.
Indication for it. So pretty much. When you don't need to do a CT is when, obviously, like if they have focal deficits, you need to do it. But if you think they have this kind of secondary altered mental status, you want to do a CT if unknown cause of altered mental status, or if it's like or if you like start treating the cause and nothing happens, get a CT. So unless you're really sure, like I know why they're altered, I'm fixing why they're altered, and it's improving. If that's not the case, go get a CT. So you don't always need it, but a lot of times you will get a CT. And there's other reasons that NPH sometimes be called on a CT scan. Someone that has chronic like subdural can get called on CT scan as well. So there are reasons to do it. other than obviously stroke.
I think I would also include in metabolic is also like renal and hepatic function. So like what their BUN is for regards to kind of renal function, and then whether they have hepatic encephalopathy or like risk factors for hepatic encephalopathy as well.
Absolutely, and always doing an asterixis. Always looking for that. It's huge. So CMP at all. So this is my general workup, and let's see if we kind of got to why this patient's been so weird with this general workup. Oh, another thing, the last thing before we move on that, be very liberal with thiamine. It doesn't hurt anybody. And, you know, giving it can potentially, especially if it's in patient where you have at least some suspicion that they'd be at risk for malnutrition, alcoholism, you know, you really want to give that up front, especially if you give them glucose, things like that, you can worsen Wernicke. So just be pretty liberal with thiamine. All right. What did we get back that were pertinent positives of this?
Sure. Your pertinent positive is your calcium's 14, and your alk-phos is 424.
Alk-phos.
Yeah, and your albumin is 3.3.
Nice. All right. 323. Sorry, what?
3.3.
3.3. All right. I think before we break y'all up into groups, I think we kind of have the reason why we think this patient may be a bit altered. But what would be your next step that you would want to get with this calcium, really to narrow your differential diagnosis and to, you know, complete this further workup?
Parathyroid hormone.
Perfect. So why don't we just, before we do a quick breakout, let's give you all the PTH, and then we'll have you break out for a bit. So what was that?
1.
So PTH is 1, which is low.
Yeah. Picograms per milliliter. The lower limit in our system is 11.
Okay. We got a question. Do we? No. All right. So now I think let's focus on, I'm going to put you on to breakout rooms, but let's focus on 2 things. We'll focus on, diagnosis, you know, differential, next steps, but also how are you going to manage this patient overnight?
Because this happened 2 nights ago.
Yeah, so I think let's focus a bit on management, and when we come back, we'll go into both of those, okay? So let me throw you all into rooms. We'll do 4 rooms. All right. See you in a bit.
It's funny, you're now more marketable because you've learned how to use Zoom so well.
I know.
You know how like you do like Excel and SAS for like statistics.
Dude, it's like
Get out of here, Amanda. You Danielle.
What's happening?
Join the breakout room.
Oh. Where are they?
Click on breakout rooms at the bottom of your screen.
What's the question?
Help
it's
figure out.
hypercalcemia, and it's with a low PTH, and it's what's the next workup
Okay.
and treatment of this patient.
I don't know how to do this.
God damn it, Amanda.
I'm sorry.
No, just kidding.
I lost the link for a second, but I'm here.
Sounds right.
Hypercalcemia, low PTH.
Oh.
Wow. Oh, wow.
Get out of here.
Okay. I don't know.
Go
You have
join
to,
a group
do you have to
and learn
click it?
things.
Amanda, you can just chill if you want.
Oh, you have to click it for me?
What?
I
How?
already made the breakout rooms. Everyone is, there.
Sorry, I'm late.
That's okay. Don't worry.
My husband's going to Mexico without me.
Who's going to Mexico?
Jovi,
Why?
for a wedding.
Oh my God, he
So I was
hates
saying
you.
goodbye because he's gonna not miss me at all.
Oh my God, he hates you.
I know. Joe was like, "Are you even married?" I was like, "Yes."
How long is he going for?
Just the weekend.
Oh, that's not that.
Yeah, but he's borrowing my sunglasses. Like he couldn't find his sunglasses.
Wow.
God.
No, he's
Let's
gonna
be
wear.
real, you have more than one pair.
I have tons, but they're all like lady sunglasses.
What's the difference?
I know.
One, you look fabulous.
All right, what do you think, Nav? Let him back?
Give him a minute. It's already 8:10. Son of a bitch.
I know. I wasn't thinking I was going to go into altered mental status this morning. You know, just booping, bopping.
Yeah, I hear you. We got to talk about olive calcium still, right? Yeah,
That's the problem. Hey, I'm gonna take it. I'm gonna take it right up to 8:35, though. You know I will.
Yeah, you know. I don't actually. I should have paid attention to when you opened them. I wasn't looking at the time. I
So
guess.
this is what happens when we're in the breakout rooms. It's funny.
Yes.
Don't you dare reveal our
I
secrets.
get to see the behind the scenes. When you're like, what time is it? Should they come back? I don't know.
Yeah,
Yeah, we never
literally
know.
have no idea. Oh, Nick.
Yeah, bro.
There was this idea that Chris had kind of pointed out. It's basically it's like a Google Docs thing. I think I can't remember what it's called. It's like Idea Pad or something like that.
No, I don't have the bandwidth for this right now, brother.
It was for the breakout rooms.
Here, let me close them. We'll talk about it after the conference. I was like, dude, I literally started getting nauseous when you started talking about that. All right, I'm gonna close the rooms. I can't do another change in my workflow.
Only has 2 more months. Let him be.
Let me be, dude. I'm on my way. We're on our way out.
Yeah, lame duck chiefs.
Lame duck cheese. All right. I think everyone's back. Before we're gonna go, I mean, this is not that well made now that I look at it, but this is my what I use for going over hypercalcemia. So you have kind of 2 different big buckets for this. You have PTH mediated and non-PTH mediated. So before we go into non-PTH mediated, which is really this patient, these are the patients who have a low PTH. Let's first go into PTH mediated. So real quickly, what are the causes of hypercalcemia with elevated PTH?
Primary hyperparathyroidism.
Perfect, yeah. So primary hyperparathyroidism. So if you remember what the parathyroid hormone does, it's basically for calcium. So it increases GI absorption of calcium, increases osteoclast, and it also, decreases renal absorption. Decreases renal excretion of calcium. About 15% of these are from hyperplasia of the parathyroid, and about 85% are from an adenoma. What is going to be your urinary calcium for these patients?
Should be high.
Yeah, so urinary calcium should be usually greater than 200 is the cutoff. And yeah, it doesn't really make that much sense, right? Because, PTH does decrease your renal excretion of calcium. But remember, it's from hyperplasia and adenoma. It's pathologic. And eventually your kidneys actually have a escape from parathyroid hormone where basically the system gets a bit overwhelmed and some of the calcium to get away from the body has to go through the kidneys and it's excreted because there's high calcium levels in the body. Now, what else is on the differential when you have for these patients with a high PTH?
Pretty sure idiopathic hypocalciuric hypercalcemia is one of them.
Yeah. So, and what would their urine calcium be for heat?
It's actually low. That's a good differentiator between that and primary hyper.
Yeah, and usually less than 100. So, familial hypercalceuric hypercalcemia, FHH, kind of an interesting pathophysiology. So it's actually a loss of function mutation on the receptor for calcium on the PTH gland. So usually this receptor for calcium binds, and then that decreases the amount of PTH that the gland secretes. But loss of function mutation, it doesn't see that calcium, so the gland secretes more PTH. So you have an elevated PTH from that loss of function receptor. This is benign, it's familial, it's basically just the set point's a little bit off. So there is not any escape from the parathyroid hormone, and their kidneys are really able to not secrete any of their calcium. So they have like no calcium whatsoever in their urine. The only other one I'll go into quickly, because this is kind of just rare, is actually patients who are on lithium. So lithium does kind of a similar pathophysiologic mechanism. It binds to that calcium, that Caspar receptor, and that's supposed to be lithium. And when that binds, the calcium cannot bind. And that also causes secretion of PTH. So lithium is actually weirdly also on this differential as well. Kind of rare, but something also to think about, and we'll also usually have a low urinary calcium, which is pretty cool. All right, so let's kind of go with breakout group 1. What kind of stuff are you thinking about? Maybe Evan?
Hey, so we
Evan.
we talked a lot about management, but we also we figured that this was a non-PTH mediated. We talked about possible like malignancy or like a PTHRP mediated.
Perfect.
I don't know how much you want me to give.
That's it.
I think we got our first bucket. So PTHRP. So what cancers usually secrete PTHRP? Does anyone know?
Squamous cell carcinoma of the lung.
Yeah, lung.
Yes, squamous cell, absolutely. So it's like squamous cell, renal cell, breast are like the biggest ones. So you got this cancer here, and that cancer basically, it's a paraneoplastic syndrome. It secretes PTHRP, and that does the same thing as PTH. So perfect. So we got that in there. All right. Do you guys want to round out the other causes of malignant induced hypercalcemia real quick? Anybody?
I guess myeloma.
Yeah, multiple myeloma. So, you would send off an SPEP, UPEP. And then
Leukemia.
Leukemia does,
Lymphoma.
yeah, leukemia and lymphoma does it as well. That's actually from cytokine causing cytokine release from leukemia and lymphoma causing osteoclast activation, bone resorption. And there's kind of one last one. It's more local. That's a rare, yeah, I'll get into that.
Our
This
group
patient
had
also has back
mentioned
pain.
sarcoid.
Okay, yeah, so we got Anita and Anita, you want to do breakout group 2? I think you said, so that's like granulomatous disease. Does anyone, do you know the path of why that happens? Here's a little long.
Let's do with the alpha-1 hydroxylase.
You have increased production of vitamin D, I think.
Yes, from macrophage, exactly. So macrophage 125, OH vitamin D, from 1-alpha hydroxylase, exactly. So granulomas, rarely lymphomas can cause, especially I think Hodgkin's can can actually have a granulomas response sometimes, and they can actually do this as well. That's very rare. All right, so this is my picture of the lungs. This is the patient with their hyaline-lymphadenopathy with granulomas. All right, I think we got breakout room 1. We got breakout room 2. How about breakout room 3? Anything else that you guys want to add in there? We got Candace, Kathy, Rahid, Rebecca, Sahaj.
We didn't really have anything else for the differential. We were pretty convinced that it was malignancy induced with a calcium of 14. And then the extensive smoking history, we agree with Evan, maybe a PTHRP related process. So we mostly talked about management of hypercalcemia.
Yeah, and then we'll get at that soon. He's also got some back pain. What could that be a sign for malignancy?
We were thinking mostly just metastasis from whatever the primary malignancy was.
Yeah, exactly. And that's one you think about. You have to think about metastases going to bones, causing actually just local destruction, once again, local cytokine release, osteoclast activation, bone resorption. Absolutely. All right, so maybe I will just round this out then, unless group 4 has anything to add. That's any other causes?
We didn't talk about this for him, but I think you can also have like vitamin D toxicity causing non-PTH mediated.
Yep, exactly. And that's kind of, I put that in, let me switch slides here. So I put that kind of sorry for this picture. I put that kind of in that intake as well. And that's when you start thinking about milk alkali, 25 OH vitamin D, thiazides too. The last one is kind of rare. You can get it from bone turnover, so hyperthyroidism, as well as immobilization, but that usually has to happen with something else. So immobilization in Paget's disease can do it sometimes, but immobilization and any of these other causes is actually going to be really bad. So someone who has cancer, bone mets, they're then immobilized, that will then, actually worsen their hypercalcemia. So I think what happened with this patient, before we get to management, they had a CT scan.
Yeah, and a CT scan, and it showed what was concerned for like a porcelain gallbladder, concerning for a cholangiocarcinoma, right? And then we sent a couple of tumor markers, and the CA19-9 was elevated significantly, like in the 2000s.
Okay, and then how the rest of these, so that a bone met as well, right, in the back?
Yeah, most likely he's pending an MRI.
Okay.
Right, but yeah.
And for bone mets, the workup is if they have pain somewhere, that makes it kind of easy. You can do an X-ray or a CT, but really the most sensitive and specific thing for a bone met is going to be an MRI. Always remember too, bone scan may not be helpful. Bone scan basically is a radionuclide labeled something called MDP, and that basically goes to the osteoblast, and then the osteoblasts take that, combine it with hydroxyapatite to actually lay new bone formation. So that only works for osteoblastic disease or mixed disease. If something is purely lytic and you do a bone scan, you're not going to see it. So, usually you need to do X-rays, CTs, and, the most sensitive and specific would be like an MRI. How about the rest of the stuff? Did you ever get a PTHRP?
That's pending still.
Okay. So
it takes a couple of days to come back, and same thing with vitamin D levels.
Okay, so those are all pending still. Cool. So Evan, why don't you tell us about how you would want to manage this patient? So this is my chart I made for management of hypercalcemia, and I kind of put into couple buckets: mild, moderate, and severe. So what were you thinking, Evan?
So I'm really happy because I was guessing the cutoffs and I guessed here, so that was good. So the first thing that we talked about in our group was fluids as management. And like, I think the recommended like starting off is pretty high. It's like 200 cc's per hour or something. And you titrate the urine output.
Yeah, and then urine output is about, you wanted about 100, like 100 to 150. Okay. So perfect. So that brings us kind of to IV fluid. So what happens with patients with hypercalcemia? It's really this really nasty, basically refractory loop that basically worsens their calcium and also actually worsens their volume status. So high calcium does a couple things. One of the things is that, calcium works on smooth muscle. So hypercalcemia actually causes afferent vasoconstriction into the glomerulus, and this can cause the patient to have an AKI. The other thing that actually worsens their volume status is that, in the collecting duct, it actually causes a nephrogenic DI. So it shuts down ADH completely. That decreases that water absorption, and then these patients just start peeing out tons of water from this hypercalcemia. That then puts them into a contraction alkalosis, which then actually causes increased reabsorption of calcium. So they kind of get this really nasty feedback loop with dehydration as a fundamental principle that worsens it. So like Evan was saying, the biggest thing is, IV fluid. So I'll do this one real quick that, mild patients, you don't really need to do anything, just treat underlying cause. And that's kind of what you're going to do for all these patients, right? You're like, why are they hypercalcemic and how do we treat it? IV fluid, once you get above 12 to 14, so if someone's like 12.5, they're completely asymptomatic outside the hospital, you may not need to admit them, but if they have any symptoms at all and they're in the moderate range, they need to come in for IV fluid. Anybody above 14 needs IV fluids. So IV fluid for all patients if they have severe hypercalcemia. Okay, what maybe group two, breakout group two? Do you guys anything to add to this?
We talked about using calcitonin. So.
Perfect. Yeah. So when to use calcitonin? So remember with calcitonin, it worked quickly. But does anyone remember that little buzzword of why it stopped working within like 2 to 3 days?
You get tachyphylaxis.
Tachyphylaxis, yeah. So, I mean, calcitonin you're going to use if they're anywhere above 12, but only if they're symptomatic. So this patient was symptomatic. I think calcitonin was used.
We did 0.4 units per kg, 4 doses over 12, every 12 hours. So a total of 48 hours of calcitonin.
So this patient, was symptomatic, so got that as well. And then just from the way I remember this is like if someone's asymptomatic and they have a high calcium, like you have time to fix it, right? It's not causing them any injury at that moment. It's not causing them any altered mental status, any of those typical groans, moans, psychogenic, like whatever, psychogenic overtones, whatever. Yeah, if it's not causing that, you got time, so you can use other things. If they're symptomatic, like you got to fix it quick, and calcitonin is the way to do it, as well as another medication. For group 3, any thoughts? Candace, Kathy, Rahid, Rebecca, Sahaj?
We talked about bisphosphonates if their calcium's over 14 or if they have malignancy-induced hypercalcemia.
Yeah, so when to use bisphosphonates, exactly. So you're saying you would use it in this case?
Yes.
Yeah. So if they're over 14, all patients get, or whatever, we're pretty much done anyway. If they're over 14, all patients get bisphosphonates, right? If they are 12 to 14, it's either if there's symptoms, but when you're on Blue 3 and that cancer patient comes in, and they have bone mets and their calcium's 12.5, like that's a component of really trying to correct the underlying cause and treating the underlying cause. So it is also long-term treatment of malignant. So in this patient, kind of was symptomatic and also, I guess, moderate. I don't know, it's 14, so somewhere between moderate. But they got all these things. So this is kind of where our patient came in. Had all these things and had some decent resolution of the hypercalcemia.
Nick, can you? Sorry, go ahead.
Do we use steroids in malignancy?
Great question. I forgot to mention steroids. Does anyone know when you use steroids? This is a good question and one they like to really get you on the boards for. It's only for a certain reason for hypercalcemia. Oh, actually, for steroids, I don't know about malignancy. I actually have heard that you may use it.
Yeah, usually it's not going to be like an overnight decision kind of thing, but I haven't found anything that's like very consistent, like that's very obviously consistent when to use it. Almost kind of like
anytime you suspect granulomatous like etiology,
exactly,
is when you should use steroids. So especially if you think the underlying mechanism, of course, there's sarcoid as a thought, but even if you have like a really bad lymphoma, it can be helpful in those situations as well. And the only other thing I wanted to add for bisphosphonates, the way I kind of think about as like management decisions, sometimes you might be starting calcitonin and bisphosphonates at like the same time. Calcitonin like almost acts as a bridge to the bisphosphonate because the bisphosphonates takes a lot of time. By the time you start having calciphylaxis from calcitonin, the bisphosphonates start working on bringing that calcium level down. And the other thing I wanted to say was, what's a contraindication, or what type of patients can you not even give bisphosphonates?
I was going to ask that one, Nav. Good question.
Jaw disease.
What was that? Sorry?
I think if they have like really bad teeth or already have like jaw pathology.
Sure.
Jaw osteo.
All of those are definitely true, but maybe looking at this on this graph, you really only have, especially in those severe patients, you have only one other option because something's not working.
Katie, severe renal impairment.
Exactly. Yes.
Does anyone know what you would use instead?
You can use that, what is it called? Denosumab or?
Yeah.
Yeah.
Nice.
Yeah, exactly.
Very good.
Hey, what if they have hip fracture, like an intertrochanteric fracture?
What about it?
I thought that bisphosphonates are contraindicated in people who have hip fractures because they could cause hip fractures, but I'm not sure.
I'm not sure about that one, Nick. I thought that you could.
I think you still can. And there is a risk. This might not be answering the question totally, but there's a risk of like these very atypical fractures with bisphosphonates. But they did like a basically long-term review of these eight weird atypical fractures, and it's like there's such low risk for bisphosphonates causing these atypical fractures that the benefits of bisphosphonates far outweigh those
yeah.
risks.
From my understanding, also, like you just repair the fracture and keep getting bisphosphonates.
Yeah, that's my understanding as well.
Yeah, and then the thing is, denosumab is going to be long-term therapy as well, I think.
Yeah. Anything else?
Can either of you comment on the utility of Lasix and
yes.
the choice of fluid?
Only if volume overload. So looking about that pathophysiology I just went into, one of the prime reason of why these patients get into this kind of vicious cycle is that they have severe volume depletion. And really with Lasix, like you don't want to start giving Lasix as it can kind of worsen the severe volume depletion that they're already in. So Lasix you only give if you start giving them IV fluid and they're volume overloaded and like oliguric, then you will give Lasix, but it is not routinely recommended. It used to be a long time ago.
Yeah, I would just think of it as like the only way you're actually getting that calcium out is through your urine. And so I almost like, I guess as a rule of thumb to myself, based off the pathophysiology, never give Lasix on like day one because I know I'm still topping them up. But if their urine output is still low after like significant volume repletion, and now I'm worried that they're kind of headed towards volume overload, that's when I might give PRN Lasix to see if I can kickstart some urine.
And the last that just finished off this management, because we're getting up to 35, is dialysis. You know, really, if it's severe and refractory, they're like you can't get it all from their oliguric, they're not peeing. And then UpToDate said if you're starting to get their calcium levels up to greater than 18 or 20, you should kind of just think about routinely using it because these therapies are unlikely to fully work. That's kind of when you use dialysis. Any other questions? I'm not sure about the femoral neck fracture one, to be honest. So I'll try to look that up and maybe send that out to you guys later. All right. Later, y'all.
Hey, Mary, are you still on? Hey, Nick, do you usually choose LR instead of normal saline in these cases?
I think you actually stay away. Good question. I think you stay away because it has a little calcium in it.
Yeah.
It's a good question.
Okay,
I didn't
gotcha.
go into that. Yeah, I think it has like a little bit of calcium in it, so you don't really want to use LR. It's like one of the only times you don't use LR. So much stuff.
Thanks, guys.
All right, see you, man.
See you, dude. Oh,